Hello. I would like to welcome everybody for this IC. At the outset, I would like to offer my thanks to Reddy sir for giving me this opportunity. Today's topic, understanding point-based analysis of visual field and the indication of 10-2 testing. Now first I will go for the understanding of the test point locations. A 24-2 size 3 white CETA standard threshold test usually is the best choice for a perimetric test for glaucoma patients. The HFA30-2 test pattern measures visual sensitivity at 76 locations within 30 degrees of fixation. The 24-2 test pattern consists of 54 test points which are spaced 6 degrees apart. Over time, the 24-2 test pattern has substituted the 76 test point 30-2 test pattern. Now I am comparing test locations between 30-2 and 24-2. Now those are completely red here, they belong to 30-2, and those who are combination of blue and red, they are common for 24-2 and 30-2. Here is the 24-2. Now come to the central and paracentral test points for central 12 points. Already we have discussed that in the 24-2, 54 test locations. Out of 54, 52 within the central 24 degree plus 2 nasal locations near 30 degree. The innermost 12 of the 54 test locations, these are the centralmost 4 points, are within the central 10 degree around fixation, and 8 surrounding paracentral points. These are the paracentral points. Now why these central and paracentral points are important? Just to understand test point locations and related initial visual field defects. What are they? IPFS and INS. Now in the 24-2 visual field, the pattern deviation probability plot can be divided into 2 subfields, that is initial parafoveal scotoma and paranasal scotoma. By definition, initial parafoveal scotoma is located in one hemifield here and of a 24-2 visual field within 10 degree radius, and the paranasal scotoma is within the nasal periphery outside 10 degree of fixation. Here I am comparing 24-2 and 10-2 test locations. In 24-2, here in the central 10 degree we have 12 points, whereas in 10-2 we have 68 points, and now is the 24-2 and 10-2. Now just see here only 12 points belong to 24-2 to understand or measure the problem in central visual field defect, whereas 10-2 has 68 points. Here I am comparing HFA 24-2, HFA 10-2 and Octopus G, G1. Next I am coming to the second part of our my topic, that is the indication of 10-2 testing. Just we start with a case presentation. Now this patient definitely, this is a loss here, and he is a glaucoma patient, normal tension glaucoma, 40 years old, and when we just did our 24-2 in 2010, patient had only this defect, just centralmost 1 point, single point defect. And 2012, the patient presented with initial parafoveal scotoma. Now on the same time, 2012, we did a 10-2. Now just see, this is a dense scotoma, right? Superior arcuate. So the central visual field defect is missed by 24-2 visual field test. Now here are more examples here. The underrating of central visual field defect by 24-2 visual field. Here in all these case central visual field defect, and the central 12 points, they either underrated or miss the central visual field defect, whereas in 10-2 test pattern 68 central points. So we can find that is an arcuate scotoma, and please note in every case the mean deviation and pattern standard deviation are there more than the in 10-2 more than the 24-2 visual field test. Now just I'm touching the structure function. Temporal half of the optic disc has two vulnerable regions, superior vulnerability zone and the inferior vulnerability zone. The inferior vulnerability zone here is associated with the inferior macular retinal region, the region of the overlap of the macular vulnerability zone, that is a red circle here. This is very important area and this is called macular vulnerability zone. The SVZ does not overlap the region of the disc associated with the superior macular zone. Now why these things are important? Here the vulnerability zones and the 24-2 visual field and 10-2 visual field points, I am just relating them. So again I am coming to this area is very important and its more vulnerable macular region projects into the inferior quadrant. Now I am superimposing 24-2 visual field points, 10-2 visual field points on vulnerable zone. Please note, first is the 24-2 visual field points. Here the location of the 24-2 visual field test points, they on the temporal half of the optic disc. Next is the 10-2 visual field points. Here we are superimposing in the macular region. And the last one, you can see here a fundus view with the retinal ganglion cell thinning map with the location of the 24-2 visual field test points. Please note here, now these 4 points are definitely outside the retinal ganglion cell thinning area. So this is the main reason why 24-2 visual field either underestimated or missed, underrated the central visual field defects. Now these are more examples how 24-2 missed or underestimated central visual field defects. So the most commonly used central 24-2 threshold test 6-degree stimulus spacing can commonly miss defects within the central 10 degree of vision and underestimate damage to the macula, the most essential region of the retina for everyday visual functions such as reading, driving and face recognition. In some glaucoma patients, in the early stage of the disease, glaucomatous macular defects can be present and the central visual field may be affected even as the initial visual field defect. Now why 10-2? Whether to deploy a 10-2 test grid in addition to 24-2 or in lieu of a 24-2 equivalent, what is the purpose of deployment? Is it to detect a central visual field defect or to characterize a defect or to measure progression? Now gradually we will just try to answer all these questions. Now please note that although the macular damage is seen on the 10-2 visual field, a 10-2 visual field test alone will miss defects picked up by the 24-2 visual field. So 10-2 visual field doing alone is not the answer. Next, performing both 24-2 and 10-2 tests is not practical solution to this problem. So what we should do? We can modify the 24-2 visual field test by adding test point from the 10-2 test pattern. Testing that targets central and more peripheral visual field regions has been explored. What we did, modifying the 24-2 visual field test by adding test points from the 10-2 test pattern, 3 modified 24-2 visual field test patterns, 24-2 plus 4, 24-2 plus 16 and 24-2 plus 16 empirical were simulated by adding 4 or 16 test points from the 10-2 visual field. So now we have 24-2C. You can see in the centrally 22 points, 12 from 24-2 and 10 from 10-2. Now here there is no central visual field defects and central 22 points are encircled by red circle. Now I am comparing 24-2 and 24-2C. Why? Because just to know whether 24-2C can solve this problem. So there is inferior damage on the optic disc. OCT confirmed that damage. Now comparing 24-2, 24-2C, here you can see in the 24-2 definitely superior hemifield, upper hemifield defect, and 24-2 definitely there is a more clusters, more abnormal points. I am comparing more. So we are comparing mean deviation, pattern standard deviation, mean sensitivity and clusters. Now definitely more clusters we can find in the 24-2C, plus please remember the benefit of 24-2C in clinical practice is not clear in structure function correlation. Identifying cluster using the 24-2C is not appreciable. So now I'm comparing 10-2 and 24-2C. Here you can find that it is function, this is structure, and this is function structure mode. Definitely 10-2 here is identified more structure function than the 24-2C. So, though 24-2C, they find, clusters, abnormal clusters are more in 24-2C. 50% of the visual field test location do not coincide with a commonly used macular thickness map. Now I am comparing all three, 24-2, 10-2 and 24-2C. So here you can find this is a central visual field defects, 40-year-old man, and definitely central most defect here, right? And definitely we can see it is also in the 24-2C. But you can see 10-2 definitely is more reliable here to identify central visual field defect. 10-2 identifying more central visual field defect compared to the 24-2C. So summary of this section, 24-2C, 24-2 and 10-2 test grids return similar global visual field indices in situation where central visual field defect is present. There is a dose-dependent relationship in terms of the structure-function relationship where more test locations lead to greater structure-function concordance. 10-2 has a high rates of concordance followed by 24-2C and 24-2. 24-2C failed to provide critical number of test locations at which structure-function relationship may be maximized. Now we can conclude that for detecting central and peripheral glaucomatous visual field defects at the same time, 24-2 poorly detects central defects, 10-2 alone misses defects detected by 24-2. 24-2C has poor structure function concordance. It is time to modify or replace the 24-2 test pattern to better detect macular damage due to glaucoma. So here is a book on central visual field defect. It will be going to be released today, this evening, and it's prefaced by Professor Robert Weinreb, and this is a flyer of this book. Thank you all for your kind attention. Thank you.